Hi, everybody, and welcome. I'm so excited that you're joining us today. My name is Jen Elder. I'm the director of SAMHSA's Homeless and Housing Resource Center, and really excited about this webinar today on Xylazine, an introduction for service providers working with unhoused individuals. And I will just say personally, I have learned so much from the panelists today while we were working on putting together this session. And so I'm incredibly excited for you to hear from them, for you to ask your questions, and just to learn a lot today about Xylazine. Next slide. So as we get started, a quick disclaimer from us: we are funded by the Substance Abuse and Mental Health Services Administration, but the views and opinions expressed today don't necessarily reflect those of SAMHSA or the U.S. Department of Health and Human Services. Next slide. We are joined today by our American Sign Language interpreters, as we are with all of HHRC events. We also have a live captioner, so you can access closed captioning if you'd like to, by clicking the option on your screen. If you have any technical difficulties, please reach out to us via email, or you can send a note to us via the Q&A. Next slide. A couple very quick housekeeping items before we get started. We're so excited to be joined by a large group today, and so all participant lines are muted and the chat feature is disabled. With that said, we really want to hear from you, so we encourage you to submit your questions using the Q&A feature. Also, so many of you submitted questions during the registration process. I think we got over 600 at least. So the panelists have reviewed those questions. They used that in their preparation for the panel discussion as part of today's session. So hopefully we'll be able to answer most of your questions, but keep those coming. And due to the large group size, we may not get to everybody, but feel free to follow up with us if we haven't answered your question. The slides are available now. There's should be a link in the chat to the webinar event page. If you scroll down, you can open up those slides and follow along if you'd wish. A recording will be available in about a week. And at the end of the webinar, there'll be a very quick evaluation. We'll put that information into the chat. You should get it in your follow-up email from Zoom. And upon completion of that, you'll receive a certificate of participation for joining today's session. So with that, I think that is all the housekeeping I have. So I wanted to turn it over to Kate Gleason Bachmann from the National Healthcare for the Homeless Council, who's going to be leading today's session. Kate?
Hi, everyone. Thank you so much for being here. I'm like Jen, I'm so excited to be here with the four experts who we have and sharing this information. So as she said, my name is Kate Gleason Bachmann. I'm the Clinical and Quality Improvement Nurse Manager with the National Healthcare for the Homeless Council. I am located in Philadelphia, Pennsylvania, and we are really lucky today to have four experts joining us, also from Philadelphia. Philadelphia, at least in the mainland US, has been the epicenter of the Xylazine challenges here in the US. And so we've been dealing with it for several years and are really looking forward to sharing the information that we have based on our experience. So I'm so happy that these four folks are joining us today and that all of you have joined us. There's been so much interest in this topic. It's unfortunate that we are all having to deal with this, but also really heartening to me to see so many people interested in learning as much as they can and being prepared to support folks in their community who are going to be impacted by Xylazine in a variety of ways. So just want to thank everybody for being here. And I have a couple of housekeeping slides as well, very short. So just a little bit about the National Healthcare for the Homeless Council. We're a national nonprofit. We provide training, technical assistance, research, and advocacy in the sphere of healthcare for the homeless, and work very hard to have all of our work include the voices of folks who have experience and expertise in homelessness. Another quick note about self-care, just to encourage folks to take care of yourselves as you need to. We're talking about drug use today. This can sometimes bring things up that are unexpected. You can hear things that you haven't heard before, or that make you feel a way you didn't expect to. So please take care of yourself as you need to. That's certainly okay. A quick review of our agenda. So we're going to talk a little bit about what Xylazine is, talk about how to respond to opioid overdoses or Xylazine overdoses when Xylazine is present in your drug supply, review some harm reduction approaches around xylazine use, talk specifically about wound care needs and the wounds that can be caused by xylazine. And then we have a panel discussion that will also be with our 4 experts who are joining us today. These are the folks who are joining us. I'm not going to go too in depth on who they are because they're each going to introduce themselves as they begin their portions of the presentation. But we're so thrilled to have Hillary, Sean, Brian, and Brooke joining us today to talk about their own experiences. So I'm going to open us up a little bit here and just talk about kind of what xylazine is and some of the basic information you need to know. I know this is extremely new for a lot of folks, so we're going to start with the basics. So xylazine, which is also known as tranq or tranq dope, it is not an opioid, so it's a non-opioid, unscheduled veterinary tranquilizer. Unscheduled means that it's not a controlled substance, although there is some effort currently to possibly change that, which will have some implications down the line. So that's something we may be talking about more, but currently unscheduled. It's used as an additive in the illicit drug supply. So in veterinary medicine, xylazine is used as a sedative, it's used as a pain reliever and a muscle relaxant for animals, and it's quite widely used in veterinary medicine. It's a clonidine analog, meaning it's a medication that is similar to clonidine, which is a medication that is used in humans for lowering blood pressure, it decreases heart rate, and also is sometimes used for anxiety. That's a prescription-only medication. Xylazine has not been approved for use in humans. There were some early clinical trials many years ago, and it was found to be unsafe in humans due to drops in blood pressure and heart rate, and so those clinical trials were ended. So we do not have a lot of good data on the impact of xylazine on the human body because those trials were found to be unsafe so quickly, and they were not continued. So this is not a medication that is used in humans. Unfortunately, it's being added to the drug supply, so people are using it inadvertently. So as I mentioned, xylazine is used as an additive. It's essentially a cutting agent, something that is added to other drugs, mostly added to fentanyl. I mentioned heroin here, although in many places in the United States and certainly in Philadelphia, fentanyl has really taken over the supply. It's actually somewhat hard to find anything, certainly not that's pure heroin. But we mostly added to fentanyl-containing products. It's used because it's currently quite cheap, it's easy to obtain, and it enhances the sedative effect of other substances. Just to note, it has been found in some other drugs, including cocaine, that is less common. We don't know if that's going to change, but it's mostly currently in fentanyl-containing products. Many people who end up using xylazine do so inadvertently or without knowing because it's mixed into other drugs and they don't necessarily know what is in their supply. So the impact of use of xylazine. Xylazine causes sedation, which can be quite significant. It can last for several hours. When xylazine is used with other sedating substances like fentanyl, heroin, or benzos, xylazine appears, based on the data that we do have, to increase the chance of a fatal overdose. And this just has to do with the increasing sedation. People can become quite sedated from xylazine. It doesn't work in the same way as opioids in terms of depressing the respiratory center, but it is a central nervous system depressant. And so it can add to that effect and can make it more likely that someone may overdose. We're going to talk a lot more specifically about this, but xylazine does not respond to Narcan. So because it's often with fentanyl, Narcan is still a very important tool in overdose. However, the xylazine component of what they may have taken is not going to respond to Narcan. People who are using xylazine and become overly sedated are at risk of having injuries from falls, potential injuries just from not moving for extended periods, from being so sedated. And of course, particularly for people who are unhoused or using outside, they're at a much higher risk of theft or assault due to sedation on the street. Folks may have heard that xylazine use is associated with significant wounds. Those wounds most often appear on the forearms and the lower legs. This is a phenomenon that we're also going to talk about more. It's not fully understood why this occurs. It's important to note that these wounds, which are associated with xylazine use, can occur regardless of the way people are using xylazine. So you don't have to be injecting xylazine to have these wounds occur. Sometimes you might be smoking or snorting xylazine containing products, and these wounds can still occur. This is something that communities and people who use drugs are quite frightened by when it comes to xylazine entering the supply. So we'll talk quite a bit about how to support folks. And I'll just start, say right off the bat that we are able to heal the wounds. It is possible, even though there's a lot of fear mongering and just a lot of fear around these wounds. And with that, I'm going to turn it over to Hillary, who is going to talk a little bit about some of the myths that are out there.
Hi, everyone. I'm going to first introduce myself. My name is Hillary. I'm a street medicine nurse with Project Home. Our Project Home team is located in Philadelphia, Pennsylvania. Thank you for the great intro to the Xylazine information, Kate. And our team is a nurse-led, nurse-run primary care team. It is the first primary care-based team that's providing street-based services in Philadelphia. And I have been a registered nurse for upwards of 5 years. And I have Brian here with me, and he's going to introduce himself.
Hi, my name is Brian. Currently in active addiction. I'm currently addicted to xylazine, and I've met Hillary and the team on the streets that have treated me and pretty much helped me heal my wounds and actually kind of get better. And I'm working towards recovery right now.
Thanks so much, Brian, for being here. We're so happy Brian could join us. If you could go to the next slide. Next, we're going to be looking over some just general, myths and facts and fictions surrounding xylazine, which obviously, in Philadelphia, we've had an influx of xylazine for many years, but being able to speak at a few different conferences throughout the country, I've realized that, a lot of places across the country do not have this experience yet. So we want to make sure that people are able to be provided with this information before it's something that you have to consider yourself. So Brian, feel free to, provide any input on any of these myths and realities. But for the first myth we're going to go over is many people who have not used xylazine before are actively seeking it out. And the reality here, right, is many people who are starting to use xylazine inadvertently due to the tainted supply and end up seeking the drug only after they have developed a dependence. Most people really actually want to avoid this tainted part of the substance, but unfortunately, due to the supply infiltration in Philadelphia, it is honestly quite unavoidable. It's completely unavoidable to have this in your supply. Brian, do you want to add anything to that?
Yeah, when I came to Philadelphia, which is ground zero for xylazine, I had originally started using in New Jersey, and I'm about an hour drive away, and it's already worked its way to the supply, all in West Jersey, the Jersey Shore, and it's creeping up into North Jersey. And I wanted nothing to do with it. When I heard about it, I didn't know I was doing it. It's such gradual amounts, you don't even realize it. And by the time you do realize it, you're addicted to it. And that's really when, I came to Philadelphia. And that's when I did seek out xylazine. But in the beginning, I wanted nothing to do with it. When I heard about it and I saw the picture of the wounds, I wanted nothing to do with xylazine.
Yeah, thank you, Brian. And Kate, we can go to the next slide. The next myth we're going to go over is xylazine is causing people to become zombies. This has unfortunately been something that is a myth I feel like that I've heard in my conversations with people and presentations, but also is a myth that's been perpetuated across our social media, news, a lot, big newspaper articles, a lot of things have kind of showcased this idea of referring to zinc or referring to trank or xylazine as this zombie apocalypse. And so just to express the reality of that situation is that xylazine is a sedative, as Kate mentioned earlier, and it can cause significant sedation, especially because people do not know how much they're taking. As mentioned earlier, it's really, people are not necessarily seeking out xylazine, they're seeking out fentanyl, but the xylazine is a contaminant in the supply. So people have no clue how much xylazine is actually in their supply. And so furthermore, people are really, looking for needs in support and education to protect themselves, and also recognizing the signs of overdose and oversedation. And Brian, if you have any thoughts on this.
I'm okay.
Okay, perfect. Next slide. This is another great point, as Kate mentioned earlier. So wounds from xylazine cannot be healed and inevitably lead to amputation. This is something that I've experienced with numerous patients in the past few months, where patients with pretty significant looking wounds go to local hospitals. Here in Philadelphia, we're pretty lucky. We have numerous numbers of medical institutions, right, kind of in the backyards of most of the areas where a lot of our folks are living. But even so, a lot of our folks are going to the hospitals and being told they need these immediate amputations and skin graft. And frankly, that is actually completely untrue. We've been able to realize that xylazine wounds can be significant and look alarming, but these wounds can be healed with consistent wound care, and wounds can heal regardless of whether people continue to use or not. And I think that that's also really important when we're thinking about wound care in general for people that use drugs, but also specifically for people that are using drugs that are tainted with xylazine, is that the harm reduction principles are so important, and we'll talk about that a little bit later, but it's important to acknowledge that people might continue to still use in providing this harm reduction support to individuals regardless of whether they're using or not.
Yeah, I have obviously personal experience with this. I've been to the hospital twice for my wounds. When they got bad, I knew I needed treatment, and doctors, nurses, and pretty much all the staff there were already talking amputations, skin grafts, and I know so many people that have lost fingers, hands, arms, legs, both legs, feet to their wounds, which they ignored, and they may have gone to the hospital and they hear this news they have to stay, but they're not going to be treated for their withdrawal symptoms. So of course they leave and ignore their wounds, and really all they need is just some very basic care, some very basic understanding, and just some supplies, and they will heal. Living proof of it. I had some nasty looking wounds that have healed right up, and it's a shame people are losing limbs over this, just over some misinformation.
Okay, next slide, thanks. And now, yeah, thank you so much, Brian, for your added input. It's so important to this conversation. Now we're just going to kind of speak generally about xylazine in Philadelphia. So as Kate mentioned, xylazine first started in Puerto Rico beginning into the 2000s. Brian and I were actually talking about this in our preparation yesterday for the presentation. And then due to kind of supply chain processes, xylazine was able to kind of find itself in Philadelphia widespread starting in 2016, 2017, and it's really spread on since then. So we'll kind of talk further about that next slide. So as I mentioned, you can kind of see right here in this graph. So currently xylazine is present in over 91% of the fentanyl heroin samples. As you can see, it's really kind of having a drastic increase the amount of prevalence it has in our supply. We can go to the next slide. We kind of both, I think Brian and I both kind of alluded to these important things that are happening here in Philadelphia, but specifically here in Philadelphia, as we're dealing with a great influx of xylazine in our drug supply, it is really important that all of our providers here in Philly are doing this, but then continuing to do this as well, as making sure there's a lot of community education, overdose response, which Sean and Brooke will go over as well later from their expertise in the world of prevention point, outpatient treatment, inpatient treatment, and withdrawal management. As Brian mentioned, sometimes people go to the hospital, are told that they need this drastic treatment for their wounds, but then aren't getting appropriate support for their withdrawal. So then they're leaving, and actually then even at points too fearful to even go back to the hospital. So then one, they have untreated wounds, but then two, they're even afraid to go back to the hospital if things get worse. And ideally, our street medicine team here in Philadelphia is very small, but we try to, make sure we're hitting all the areas where there is higher rates of substance use, but we're only a team of 4, so we can only do so much. But ideally we'd be able to continue to work with more hospital partners to provide the supportive care using this harm reduction framework to support people that are still going to be using. And I think that that's so important to working with individuals, and also working with individuals specifically when the xylazine is in the supply. We really have to have this harm reduction framework. Otherwise, you're not going to get the care that the person wants. And ultimately the patient needs to be the driver of their own healthcare. This is, we're here to support the patient's desires, and we're here to make their healthcare, accessible and available to them. And so that involves regular wound care. Our team is able to meet with Brian pretty regularly to support his wound care needs. And our team, also being a street medicine team, is very mobile. And so we're able to meet people kind of wherever they're at. And then also we'll talk about this a little bit further, but another important aspect would be able to have actual xylazine test strips for people to be able to test their drugs to see if xylazine is present. You can go to the next slide. Thanks, Kate. And this, just goes to show kind of the numerous increases in the xylazine positive overdose deaths across the United States. I think, we talk about how we've been really hard hit specifically with those wounds and xylazine related concerns here in Philly, but there's a lot of xylazine related overdoses happening all across the country. And I think, if you're maybe not seeing the wounds that you'll see in the slides later, it seems like it's probably still going to be coming your way. So I think it's just really important that xylazine is here in the US. And so figuring out ways that we can best support our folks is the utmost concern to make sure we can continue to provide this harm reduction care that our patients deserve.
Hi, everybody. My name is Sean Westfall. I'm the Overdose Prevention Coordinator at Prevention Point, Philadelphia.
And I'm Brooke Petter, and I'm participating here at Prevention Point, long-term addict.
So today we're going to be talking about responding to suspected opioid overdoses with special considerations of xylazine in the drug supply.
Lately, there's been a lot of more overdoses, and people are so used to just using Narcan on an overdose that they don't realize it doesn't have the same effect on the trank. And so sometimes, like if somebody's breathing, you're not supposed to administer Narcan. You help them breathe, and you got to wait it out. And that knowledge is it helps a lot. And if people are just a little bit more hesitant to help with the sternum rubs and the alternative methods, alcohol pads, smelling salts, all things, pain is what spikes them back to life, is what gets them.
All right, next slide, please. All right, so xylazine, this was said before, but xylazine, also known as trank, is found in most dope bags in Philadelphia, especially the Kensington section where we're at. Again, trank is not an opioid, so Narcan has no effect on it specifically, but it is always mixed, or typically always mixed with an opioid. So in Narcan, we know works great on that. Next slide, please. Somebody who uses trank dope is gonna be heavily sedated. So when, in a medical emergency, right, rarely do we know if a person used drugs, what combinations of drugs the person may or may not have used. No matter what, there's always a couple of things that we always need to keep an eye on and help manage, right? So one, stay safe. Two, we're going to call 911 if the person's unresponsive. We're going to control any life-threatening bleeding if necessary. We're always protecting the person's head, neck, and spine, making sure the person has an open airway so they can breathe. We're supporting the person's breathing. We're beginning CPR if the person doesn't have a pulse. We're asking for an AED. And if we suspect an opioid overdose, we can go ahead and administer naloxone. Next slide, please. So I want people to look at this picture here. When we're talking about suspected opioid overdose, remember the mnemonic SCARE. So S, stimulation, C, call 911, A, administer naloxone, R, resuscitation, and E, evaluate. So if you're looking at this picture, you put yourself at this scene, we see a person laying on the ground. We see drug paraphernalia around the person. So we may suspect, hey, this might be an opioid overdose. But there's some other things that I want people to think about, right? Is this person breathing? Do we notice them breathing? We're taking a look at their skin. Do they look pale blue or gray? Are they becoming cyanotic? We're looking for other clues. So, somebody's breathing, that's a great sign. We see the safety issues, so we're gonna have to get those syringes out of the way. But, if we see somebody breathing, we can really slow it down just a little bit. Next slide, please. So, one mnemonic I like to use is APNU, right? So when we're checking for responsiveness, you know, A is alert. Like we're both alert, great. If you see somebody that looks like they might be overdosing and you say, hey, wake up or I'm going to give you Narcan. And they say something like, I'm fine, don't give me Narcan, leave me alone. That means they're responsive to verbal stimulation, right?
It's the scare tactic that gets them awake, just like the physical pain, or even just because they can hear us, even though they may look as though they are completely unresponsive and out cold. They're still hearing what's going on, but it's like being paralyzed and just hearing, and sometimes even having flashes of actually seeing what's going on, but being unable to speak, being unable to move, barely being able to breathe. And then you want to tell them that you're okay, you don't need more of this medicine, but because it's not going to get them up, like you need help, you need to wait it out, you need to help, like Sean said, monitor their breathing. If they're breathing, the sternum rub works great to go in and out with their breaths. If you follow their breathing pattern, it's an excellent method. It takes a little bit of time and a little bit of muscle strength in there, but you could really get somebody back with that.
So as Brooke said, using P, evaluate responsive to painful stimulation. Great. And, we're able to get that response. If we're unable to get that response, the person is unresponsive, that's when we're starting to think about Narcan. Next slide, please. So this is an important point that I want people to think about. So when a person who has an elevated tolerance to fentanyl uses tranq dope, which is fentanyl and xylazine, it can be very likely that the person did not use enough fentanyl to cause an opioid overdose, but it's enough xylazine to heavily sedate them for hours. Next slide, please. At first glance, it can appear like an opioid overdose. The person might be looking, in a very uncomfortable looking position, maybe out on the street. But in this case, the person's breathing and oxygen saturation levels are going to be pretty close to normal. It's not an actual opioid overdose. We should be able to elicit some visible response when applying that painful stimulation. One thing I like to use is a little, when a person's breathing, normally their oxygen saturation level is good. I might do that sternum rub. If they don't respond, or maybe I see some response, I'm going to maybe use a little bit of water. If I have a little cup, I'm just going to fling it in their face a little bit. I might give them a couple of nice jets to the forehead. Next slide, please. So again, usually what we see, unless the person is in a position where they're closing their own airway off, maybe face down on the ground, or their head is positioned down. Again, usually people's oxygen saturation levels and respiratory rate is normal or near normal. That's what we see a lot on the street. So again, in those cases, we do use those extra measures to try to wake them up. A little bit of water usually works great. Again, if somebody is not breathing, I'm not using water or anything like that. Next slide, please. So one thing that, I want people really think about is, before reaching for that Narcan, which is a wonderful medication, I want people to think about the ABCs, airway, breathing, circulation. We're making sure the person has nothing in their mouth. And we're taking the time, no more than 10 seconds to check for breathing and a pulse, right? So if we notice something in their mouth, we want to get the person laying flat on their back. We want to check, their mouth. If we see something, carefully take it out. Checking for a pulse, look, listen, and feel for breathing. Next slide, please. If we cannot find a pulse on a person, we're jumping and doing CPR, starting with 30 compressions, followed by 2 breaths, asking for somebody to grab that AED. We're going to give Narcan as soon as it's available. If a person has a pulse, but is not breathing, we're going to begin rescue breathing, give the naloxone as soon as it's available. If a person has a pulse and is breathing, but is unresponsive, we're going to roll them into the recovery position so they don't choke on their tongue or vomit, and administer naloxone as soon as it's available. Next slide, please. So some typical vital signs that we're looking out for when we're doing street outreach and overdose response. Some of these may not be relevant, but some major ones: respiratory rate. We're looking for, is the person breathing? How well are they breathing? We're also using a pulse ox, checking their oxygen saturation level. Usually, like I said, the respiratory rate and oxygen saturation level, if it's not an actual opioid overdose, if it's just heavy trank sedation, is going to be pretty normal. Their heart rate can be low. Pupils, we know with opioid overdose or opioid use, we have constricted or pinpoint pupil, right? So we are checking the pupils. Skin, is the person cyanotic? Are they pale blue or gray, right? Blood pressure, when somebody uses xylazine, their blood pressure can drop pretty low. Next slide, please. All right, so I think we'll be back shortly.
Okay.
Perfect. Awesome. Thanks so much, Sean and Brooke. It's really good to see you. So here I am back. Brian just went to the bathroom, but he'll be back shortly. He can hop on in. So we're going to talk about some harm reduction approaches. I know I've been looking at the Q&A a little bit and just wanted to also just highlight some of the questions I saw so far. What is a street medicine nurse? In case people don't know, as I mentioned, I'm a street medicine nurse. So I work to provide healthcare as a registered nurse with a medical team consisting of 3 other family nurse practitioners, and we provide primary care services on the street where the person lives. So we can go to train stations, bus stations, under bridges, and encampments, on the street, anywhere where the person is, and that's where we're able to provide this care. Next slide, we received, if you want to change to the next slide, Kate, I received a lot of questions about Xylazine test strips, so this is a perfect segue. So there are Xylazine test strips available in Philadelphia. We're able to access them through our public health department. Just a little caveat, I think important to note is that we importantly need to just be aware that it's important to talk to your local public health department about accessibility to Xylazine test strips. I know certain states and jurisdictions actually outlaw people from having these Xylazine test strips on their person. So this is something to just make sure that you talk directly with your public health department. And also I realize this might be your slide, Sean. So do you want to hop in and add anything to this? Sorry, I can sign off.
Thank you, Hillary. Yeah, that's a great point. Know what the laws around test strips is in your locality. They may be considered drug paraphernalia, and you could be charged with that. With that being said, both fentanyl test strips and xylazine test strips are available online. You can even get them on Amazon nowadays. Fentanyl test strips, xylazine test strips are really used only to test opioid substances for the adulterant xylazine. They are a great tool to have. They're very sensitive. You do have to get the dilution rate proper, but they're used just like a fentanyl test strip. Remember, there's 2 letters in the word no. 2 lines means a negative result or no xylazine. I've picked up a empty scraped blue baggie off the sidewalk, or a cooker that was used off the sidewalk, put about a teaspoon of water on it, dipped a test strip in it, and it was sensitive enough to pick it a positive up. Another thing that clinicians can do is they can add this to their urinalysis drug screening. They can just add that to it, right? So if you have a client or you yourself believe you may have taken xylazine, you can test your urine with these strips because that's what they were originally designed for. And that's all I got on this one. Thank you, Hillary.
Perfect. Sorry about that, Sean. Okay, now back to us, and Brian's here with us now. So perfect. Going to talk about healthcare and hospitalization. So this slide kind of just shows between 2013, 2018, the number of hospitalizations for skin and soft tissue infections, an osteomyelitis, which is a bone infection, and bacteremia, which is a bloodstream infection, as well as sepsis and infective endocarditis, which is an infection related to the heart valves, has really increased, you know, across those past few years, which is just really something to note. And obviously coinciding with the, you know, increase in xylazine, it's important to also consider kind of what this data will show once they're able to kind of get more data that's more current. It's really important when we're talking about healthcare and hospitalization. So the healthcare system can be really complex for our patients to navigate. And if you have any ability within your team, your department, your outreach, whatever organization you're coming from, to support individuals when they go into the hospital, or be able to kind of, as we use the term, find the helpers in these healthcare institutions to really, you know, have an in to support our folks. It makes the hospitalization so much more effective and so much more supportive for when our patients actually need to go to the hospital. Unfortunately, there are a lot of people that see these wounds on some of our folks that aren't necessarily medical trained, or people that work with our folks every day, and frequently will think calling an ambulance is the way that needs to happen to provide this care to the person. And then if the person decides that they don't want to go into the ambulance, they are now kind of then branded by these people that, like, maybe they don't care about their health. And I think that that's another myth that we just really need to dispel, that, you know, for certain patients, although, you know, their wounds, due to the fact that they're xylazine related, they might be draining and they might be extensive. They actually don't need emergency medical attention. And frankly, if they went to the ER, they wouldn't be seen for greater, probably usually in a big city, more than 12 hours. I don't know. Yeah, Brian, feel free to jump in. And they also, you know, in that ER stay wouldn't be, you know, managing any of these withdrawal symptoms. So really it would be kind of an ineffective hospital admission for the person. And so being really mindful of when you send the person to the hospital, but also making sure that there's some embedded supports to support the person in seeking a healthcare and trauma-informed, harm reduction-based approach to their wound care and healthcare hospitalization. So Brian, do you want to talk about your experiences?
Yeah, I've lived that experience of going, you know, to the ER, and the doctors aren't sure what to do. They're mistreating me. I'm telling them, hey, I'm going to go through withdrawal from xylazine. And they're like, okay, here's some Suboxone. And obviously that does nothing for xylazine. And I've been pretty much kept downstairs at this hospital. You go upstairs and get a room once you're admitted. I was left downstairs for 3 days with no bathroom while I'm going through withdrawal. So I'm just, you know, vomiting, going to the bathroom in bedpans. It was, you know, almost neglectful. And, you know, so I did leave, and then that leaves a bad taste in my mouth. And I'm never going back to the hospital again after that. Like, I was just, I felt so mistreated. Staff seemed so misinformed that they didn't know what to do. And I just didn't want to go back. And honestly, these are just real simple wounds that just take a little education and materials, and I can handle them on my own. Any addict can handle it on their own once they know what they do and they have the proper supplies.
Yeah, awesome. Thanks, Brian, for that. And actually moving in, Kate, if you want to go to the next slide, we'll talk further about withdrawal support. So there were a few questions I'd actually noticed talking specifically about what the difference for like a xylazine withdrawal and how would you kind of spot that. So just from like my medical experience working with some of the docs that we send patients to and kind of hearing, you know, their anecdotal findings with working with our folks, we found that, you know, when folks are withdrawing, you know, obviously they need some, you know, withdrawal medication support, but when they're from fentanyl, but when they're withdrawing from xylazine, usually they are needing some clonidine or some, you know, other, you know, benzo type medications when they're in the hospital setting to help them withdraw from the xylazine, because it is quite difficult for individuals to withdraw from that. And Brian, do you want to add anything to that?
Yeah. Again, you know, there's multiple hospitals here in Philadelphia. There's a couple that are, you know, on the cutting edge of this, and they're using ketamine for withdrawals. and they're having a lot of success with that. But if you do go to the wrong hospital with these withdrawal symptoms, you're not going to be treated right. They're going to treat you for opioid withdrawal, and as you know, this is not an opioid. It does not touch the receptors, and you're just going to have a bad time. And no one's going to stay and endure that. They're not.
Yeah, and I think like this also leads to the question. I know that unfortunately kind of, this very outdated language in our medical systems that kind of refer to, even when I was in nursing school many years ago, they kind of think about how like alcohol withdrawal is life-threatening, but opioid withdrawal is not life-threatening. So it's not necessarily as viewed as critical in our healthcare systems. And I think, thinking about with xylazine specifically too, it's really important to consider this acute anxiety aspect to it and making sure that we're able to address this with the withdrawal components, because obviously if people are going to the hospital for, maybe they do have infective endocarditis and have that infection of their heart valves and really need to stay there. If there's no withdrawal management for their xylazine component of their fentanyl, like they could be on, a really good withdrawal management for their fentanyl, but have no support for their xylazine, that anxiety is going to be even more exacerbated, obviously due to the fact they're in the hospital, and it's going to be really hard for that patient to stay. And so I think that xylazine in the drug supply just begs furthermore for a continuation of care, coordination, and collaboration amongst all different parties to support our folks, and really is just really essential to continue to make sure that we're, really trying to advocate for our patients when they choose to go into the hospital. And as Brian said, I mean, we're lucky in Philly, we have multiple hospitals, and I know that's not the case for all of you. Like you might only have one hospital in your area you're working with, but I think it goes to show that there are some better hospitals in areas that are more educated. And I think usually those tend to be in the areas where people are, more connected to the substance use, and, that maybe the substance use is kind of directly in their backyard, that they've had to adjust and, get used to the different experiences of patients coming in. But I think it's just really important to make sure that we're focusing really on the withdrawal support, because if we don't have that when our patients need to go to the hospital, they're not going to be able to stay. And as Brian mentioned, when our folks have a bad experience in the hospital, it makes it even less likely for patients to go to the hospital when they're in a dire emergency. And I think that this is really kind of the reality of our healthcare system. We really have to figure out a better way to support our folks who really need the healthcare support. And we can go to the next slide. So now we have a few slides talking about supporting wound care needs. So this is something that Brian has a lot of experience with. So hopefully I'll be talking less and Brian can kind of take the stage on this. So if you want to go to the next slide, Kate. Okay, perfect. So this is just talking about xylazine related wounds. So Brian, do you want to just talk about your experience with your wounds and just kind of let us into what your experience was?
Yeah, xylazine is, pretty much meant to be shot into the veins or the muscles. So when we miss as addicts, which does happen a lot, and it's totally random too, you'll get this black wound that sometimes turns into this infection, sometimes it doesn't, but it does pretty much liquefy your skin, your tissue, your fat cells. The only thing you'll see, and it leaves this big hole, and you'll see your muscle underneath it and your tendons, and that's all you'll see. And if you're homeless living on the streets and getting high, now you're probably going to get an infection, most likely. If you like to sleep, you're going to get flies, so you're going to get maggots in your infection, in your wounds. And it's horrible. And then you go to the hospital, and we said you'll be mistreated, you'll leave, and then you're just going to ignore it. And it's going to get bad, but what can you do at that point? You have severe addiction to deal with, and you just do more drugs pretty much at that point, just to deal with all your other wounds that you have.
Yeah.
Don't care.
And that's, such a great perspective and such an important aspect of this panel here is having Brian's, content expert on this. To also add just some more points, just based on some of the Q&A questions I saw in the chat. A lot of people were asking about where these wounds occur. And so as stated in this slide, so they're characterized kind of by substantial tissue death or necrosis, but the wounds are not necessarily associated with injection sites. And honestly, for most people, we're seeing people are injecting in their arms or legs and getting the wounds in completely opposite parts of their body. Is that what you're kind of seeing as well?
Yeah, I've seen that on other people. I'm not one of those people.
Mhm.
I only get them at an injection site that I've actually missed on and it hasn't gone into the vein or muscle. I've seen guys shoot up in their veins and their veins turn black and then it turns into one of those lesions that goes along their vein for 2 or 3 inches. I know a guy who was sniffing Xylazine and it put a hole next to his eye. So after about 6 months of that, anytime he sniffed drugs, it would pour out of his eyeball. Like, this stuff destroys you, destroys skin, destroys that. It's pretty bad.
Yeah, and I think most commonly we're seeing the wounds on, I know Brian had mentioned he saw someone with an eye, I've seen someone with a wound on their forehead. Most commonly it seems that they're happening on the forearms and lower legs, but they can occur anywhere. And as Brian mentioned, they can occur at the injection site. They can also occur unrelated to the injection site. And I think that also, I know people are kind of asking about why that is. And I think, you know, there's a lot more research, and hopefully one of you out there is interested in the research of Xylazine, because we'd love to, you know, hopefully get some more information about how Xylazine works in the bloodstream to better support our folks. But it seems like there's some components of dermatology getting involved with some of the research to figure out how it impacts people on a person-to-person level, because I will say that there are certain patients that are using extensively that I work with that have actually never had a Xylazine related wound. And there are also people that are using not very much at all, maybe 1-2 bags, which is pretty low for Philadelphia, and they're receiving very extensive wounds. So I think that that also begs the difference. I mean, obviously, when you think about from pathophysiology standpoint, you know, when our folks are experiencing homelessness or living on the street, obviously their immune system is probably pretty suppressed due to the fact of their, you know, status of where they're living. But acknowledging all of those factors, it's really hard to kind of figure out what exactly is going on with the Xylazine. So this begs that call to action for all of you, hopefully out here in the webinar crowd, to maybe work with us, and maybe you can provide us some information in the future about what we can do to better support our folks. But as mentioned, the wounds usually start as small circular lesions that merge to form these large, and as Brian said, full thickness down to the fat, as he mentioned, in muscles and even tendons, and they can become quite large and extensive. And I think Alicia had mentioned this, but we actually, you can change that to the next slide, Kate. In the interim, we actually had, we have a little Word document that, or PDF document that was included, I think, when you signed on to this, that you can click on. It does have some wounds that are pretty graphic, which is why we didn't include them directly in the slides, but we encourage you, if you're comfortable, to look at those, because I think that there's one picture where it just shows a wound, but then there's another picture that actually shows the progression of wound healing. And I think that that's really important to see, that, you know, over months, an extended period of time, we can actually heal these wounds with collaborative wound care efforts. Now moving into the advocacy and harm reduction for wound care. So I think advocacy and harm reduction is really kind of, I feel like, the bare bones of what we do here in street medicine at Project Home, and what we do when we work with anyone that's using substances, even before Xylazine was present in the supply. But as mentioned by Brian, the wounds can be really extensive. They are frequently healed without the use of skin grafts and amputations. I know that's been said a few times, but that is just so important. As a take-home point regarding wound care, is these folks do not need skin grafts and amputations. Very rarely is that something that's needed, and they can be healed. It might take months, but they can be healed, and that's just so important for our healthcare world and our, you know, like agencies like all of you that are providing the care on the ground to be aware of. The regular wound care follow-up is essential. I think Brian, we were probably meeting you like twice, sometimes 3 times a week, and then there were a few weeks where we probably didn't see you much because we couldn't find you, but yeah.
But I was able to take care of myself because I had watched and learned, and it's not that hard. It's just really, for me, the problem is getting the supplies after a certain point, being able to change it as much as I could.
Yeah, and I think also when we talk about the supplies, we're lucky with our organization that we're actually able to bill people's health insurance. And Pennsylvania is an expanded Medicaid state, so a lot of our folks are eligible for Medicaid insurance, which I know is not the case for all of the states across the United States, which is unfortunate. But with that, we're actually able to bill our patients' insurance and have the wound care supply sent directly to our office, because as Brian mentioned, it's very hard to be able to manage wound care, the actual supplies on your own person on the street, because unfortunately there's a lot of theft. So even if there's a way that your organizations could work with a provider where you're actually able to keep the boxes of these people's wound care supply on site somewhere, and then we usually go out with like a a Ziploc gallon-sized bag of the supplies and we change them with our supplies, and then we provide them with kind of a take-home bag until, as Brian mentioned, people are able to kind of change them on their own, because ultimately our folks are, you know, responsible and have the autonomy over their own bodies, and we want to make sure we're able to support them, but also, you know, meet their needs. If they need, you know, medical touch points, we're always happy to provide that ongoing support. And just to highlight one of the pictures, that people have looked at those on that document. The one picture kind of shows the indentation of a xylazine related wound that kind of had an indentation multiple points at the wound. And that was actually due to a dressing called co-band. And I think it's just really important. Obviously, certain areas have different access to different wound care supplies, and that's totally, you know, you have to use with what you have, but just acknowledging that for folks, especially folks that are, you know, maybe still using in the wounds that you're dressing and they're taking those dressings off, co-band can be really restrictive and actually cause kind of a tourniquet on this person's wound and created a really, you know, dangerous situation that could have been prevented if you use something like conform, which tends to allow kind of some swelling to occur without constricting the wound. There are certain places that still use you know, co-band. We just ask that, you know, you provide this education to make sure that the person's aware when they're putting the co-band back on, to make sure it's kind of flat, so it's, you know, not going to necessarily cause a tourniquet if that's the only option that's available. And we also use something called Tubinet. I know it might be expensive if you're not going through someone's insurance, but this is something that actually is kind of like a fishnet stocking that you can cut on both ends. And that allows the person to be able to pull up the net and actually inject if they want to, and then put the net back down. And so that prevents the person from having to take off the whole bandage and then maybe not being able to put it all back on their own. So those are just 2 tips and tricks that we'd be happy to, you know, always kind of provide when we give presentations, just to ensure that people are aware of some options. And we can go to the next slide. So this is talking about xylazine related wounds. So I think, as we've kind of highlighted throughout, these wounds can worsen quickly and respond best when treated early. Do you have any thoughts on that, Brian?
I mean, yeah, that says it all there. I mean, right now I'm still injecting, like I said, and now when I see the wounds start to develop, you know, I have my own little process that works for my body and the wounds when I get them, and they're nothing now. It's just a simple little process. It's very rare that they get infected. I've had one maybe in the past 6 months get infected, which is amazing, because when the street team first met me, I probably had 7 or 8 infections going on me at any one time that I was dealing with. And yeah, just catching them early, knowing how to deal with it's just amazing. It's just like a little wound now. Sometimes they heal faster than just a normal cut I get, just because I know what I'm doing. I just know how to treat it and get rid of it.
Yeah, and I think that that's also, so highlights another really important point, to make sure that you're providing, I know it's really important to provide this stigma-free and judgment-free experience when working with people with wounds. As Brian said, you know, we work with many patients that are so nervous and feel ashamed when talking about wounds, because they might have maggots, they may have different things going on, but it's really important to kind of start this conversation off the bat to make sure people are feeling safe and supported, with allowing you to enter into their space in their own personal autonomy, and making sure that we're supporting people, but also providing them the resources, you know, to make sure that they're getting the 2 times a week wound care that they need, or maybe doing it once a week and then providing them the supplies for them to be able to change it the second time. And then just the last point that we always like to make is that people should avoid, which is easier said than done for people that have these wounds, is avoid picking at the wounds, or if they do, try to give the person a clean pair of gloves that they just use for that and then they can throw away after. But avoid leaving them open to air, which is a common thing that I continue to work with folks. There's this myth in Philly that you should leave your wound open to air and that will cure it. That is not true. It's not true at all. You should avoid injecting the wounds if possible, but that's not always possible. And that's why we have these harm reduction options for people. And then we also make sure your folks avoid using harsh cleansers like bleach, alcohol, or peroxide. The only caveat with the bleach is there is a really like a titrated form of bleach called Dakin solution, which is made for medical situations, that's prescribed. So obviously that solution would be okay, but not anything like straight up bleach you'd get from a grocery store or anything. We don't recommend that. Is there anything else you wanted to add, Brian?
Yeah, I mean, everything there is what I'm doing. And again, yeah, I've actually heard doctors say to use peroxide on these wounds, and there still is a lot of old thoughts in wound care that just don't work. And yeah, I mean, the best thing to do for these wounds is, cover them up as fast as possible, keep them moist and clean, keep changing your bandages, and they're going to go away fast.
Awesome. And Kate, you can go to the next slide. I realize we're running short on time because we want to go to the panel. So I'll just kind of go through this slide briefly, and Brian, feel free to jump in. But basically, we've kind of been mentioning throughout treatment and referral. So refer anyone with any type of wound, try to refer them to a medical care, street medicine team, outreach team, some type of trained medical professional or someone that's been trained in some aspect of wound care. It's really important that you're not using specialty wound dressings if you yourself or someone on your team is not prescribing or teaching you how to use them, because the specialty wound dressings that might actually be able to heal patients' wounds that you're seeing in someone else might not necessarily be the prescribed method for that patient, and also might cause more harm for that specific patient if the provider is not specifically prescribing them. When in doubt, I think the most important thing is to cleanse with the saline or clean water from even just a water bottle. You're able, like Poland Springs or some type of water bottle, you're able to clean it. That's the only option you have. That's great. And then cover with a clean, non-adherent dressing. That's the best way to go to start off until you get the person to a more, established wound care clinic, if that's what you have, and you need to wait maybe a few days. Regular access to care is important, and make sure we're referring to people, to medical people as necessary and needed. And you can go on to the next part. Thanks, Kate.
Okay, so thank you so much, Hillary and Brian and Sean and Brooke. That was all such wonderful information. And I know this is really new for a lot of folks. So I'm sure there are a lot of questions, and we could take hours and hours to talk about all these things, but I think that was such a wonderful overview. And so what we're going to do now is move on to kind of our panel discussion that we have planned. And as Jen said in the beginning, we received, which is wonderful, a lot of folks when they registered asked us questions that they had, and we got hundreds of questions and looked through to pull out the themes that we were seeing, and we tried to cover some of those in the presentation we just did, and then the other parts we're going to talk about in the panel discussion, which we'll have now. So Hillary and Sean, if you want to come on video and unmute, then we can get started. So I think first off, I'm going to just I know everyone did a little introduction of themselves. I'm just going to open it up for any of our 4 panelists. If there's anything else you want to share about the work you have done, anything that you want to follow up on from the presentation, or anything you want to share about your own personal experience with Xylazine and how it has impacted you, I'll turn it over. And you can there's just 4 of you, so it's fine to just jump in.
Yeah, thank you. Yeah, Brooke had some to talk about her experience.
So as when I introduced myself, I am a longtime drug user, addict. And when Xylazine first came around, it was more like the wounds came around and we couldn't really figure it out what was going on and why you still just didn't feel right or everything. And then my leg got really bad, and I went to the hospital, and they told me I needed an amputation, and I went with it. And 3 days in the hospital, day I got there, it was the day before my surgery. Then it was my surgery the next day. They sent me home the following day, so I wouldn't lose my bed at the shelter and be able to get my housing. But just recently, because unfortunately I have developed unwillingly and unbeknownst to my own suffrage, a pretty high, a pretty bad habit with the Xylazine now, because you never know how much is in what. Just you can only go off by how you feel about it. And like now, even though I know it destroys me every time I do it, I have to do it, because if I don't, I just can't even be normal. There's I want to get on methadone so bad. I've been a drug user for 26 years, okay? And there's no point because I'm going to be just as sick with that because it can't touch it. Nothing can touch it. And, you know, I had wounds on my arm just recently. And I guess there's a 1.5 time lapse between my leg and my arm wounds. But in that time, I went back to the same hospital that I amputated my leg, and my bone was actually protruding out of my arm this time. And my arm was way worse than my leg ever was. And they were so adamant about saving it and finding ways to accommodate me. They really have come a long way. And I just, like, the wounds, you can heal them. It does take time. It takes cleanliness. It's upkeep. It's frustrating. You hate to look at yourself like that. You worry about, can other people smell you, see you like you don't? And then that pushes you further and further into this cycle of insanity and addiction because you can't, the normal quote unquote world doesn't look at you the same. They see the wounds and they see the homelessness and we don't want this. Nobody wants this. Nobody wants to watch their flesh fall off their body and be completely helpless over it. But I want to function. You know, I'm already down to one leg and now my other leg has a pretty wicked infection on it too. And it's just like, you don't want to go in all these other places because you know this is going to happen wherever you go. And so you try to keep it in one spot so that you hope the doctors will be able to work on it and save that one spot before it gets too bad, you know, like otherwise you got it everywhere. And then that's where they get the zombie thing from, because we're not flesh eating zombies, but we're flesh eating zombies.
Can you talk a little bit about Xylazine withdrawal and what are some of those symptoms?
It's awful because, like, okay, so with opiates and even with fentanyl, you kind of know what to expect. They kind of there are certain things they can use. They're learning how to use, but xylazine, there's nothing. And it is the most uncomfortable withdrawal. If you could take the strongest aspect out of every sickness you've ever felt and combine that into one hard blow, that's every 4 hours for somebody addicted to xylazine. Just out the blue, crippling stomach pains, throwing up, like completely unable to even move. They don't want to lay on the sidewalk and defecate on themselves and vomit nobody wants to be that way, but you can't go home and be around your family like that. You can't find these drugs around there. You're stuck. What do? Treatment centers can't help you. What do? Try to stay alive until they figure something out, right? That's why we need all the harm reduction we could get. And nobody's condoning behaviors because it's happening regardless. But the thing we need access to bandages. We need supplies. We need wound care. We need syringes. We need to pass on everything we learned one by one. It's just so important because it's how we're staying alive right now.
Thank you, bro.
No problem.
Thanks, Brooke. Thank you so much for sharing that. That is so helpful and powerful. And you actually started to kind of answer the next question that we have, but I do want to give Brian and Hillary a chance if you want to add something, and then I think we'll build on what you just said, Brooke, because that was really helpful.
Thank you.
I think Brian said he was all set. I guess I just wanted to add, it looks like people in the chat were talking about whether they should carry like a pulse ox and on them. And I think that, that's a really important thing. I see Sean like nodding his head. Yeah, regardless of being a medical person or not, a pulse ox is a really great tool to have in your toolkit when providing support to folks that are at risk for overdose, as well as always making sure that, you know, it's ready and accessible and you have Narcan available as well. Thanks, Kate.
I do want to add something to that regarding pulse oxes. You can't rely on them, period. Some of them are junk when you take them out of the box. They're a great tool to have when they work, but you just cannot rely on them. And that's all I'll say on it. So if you get one, get a good quality one, but don't rely on them.
Yeah, I think I would definitely agree with that. And I think, it's an important tool and it's one of many. We use all of our, tools at our disposal to assess if someone is okay. And it definitely is one of the things that can be quite helpful. So the first question that we got from a lot of folks is, and Brooke, I think this is what you started to answer, how can, for communities that are just beginning to see xylazine, or they don't know if they have it in their community yet, or it's perhaps coming, what are some things they can do, or what advice do you have to kind of prepare to be able to, deal with all that's happening, to be able to better support people who are being impacted by xylazine? What advice do you have for other communities?
My best advice would be is if you're gonna do it, if you're using drugs and you're not sure, it's that you can't get well feeling, and if you're starting to think that there's xylazine in it, if there is another option you have, please pursue it. I mean, like if it gets to a point, you're just gonna be stuck running in a circle until we figure it out. But like, say you're curious and you suspect it, get on methadone. I mean, and get on something so you have a backup. Get on Spox and do something, just because it'll keep you from falling into that cycle of pure insanity and getting stuck into it and being forced to do it. Because if you're still being able to think about it, you're still able to escape it. It's when, you try to stop, and then you realize you can't, and then you get these wounds, and you're still, there is one point in time, I swore I watched somebody inject into a wound, and I said, oh my God, how could they do that? And I came to Kensington 13 years ago, and I was on the streets for 12 of those 13 years. And all your nevers become true. That was my never. If I ever got to that point, that was it. I'm stopping. But there's no way to. I never wanted to be that, and I had to be, because I can't just give up. Got to stay fighting for another day, because who knows, tomorrow maybe there will be something.
There's a couple of tools that I want to mention, along with the pulse ox. Emergency oxygen is a great resource and tool to have. Also, bag valve mask, these things work great. A lot of times what we're doing is the breathing support and monitoring, but those are a couple of great tools. In preparation, if you believe that xylazine is coming to wherever you're at, one thing to be prepared for, if you can, is try to get some grants or a line on wound care supplies.
Yes.
Because it will be needed, and you will go through them
Quickly.
Very quick. And
The population is accustomed to having their stuff stolen, and so like a center is very helpful, a place where people can go to actually maybe pick up what they might need for the day. Because if you give them too much, somebody might steal it, and then they don't have it, and then it's just thrown away or whatever. Things like that will be very important, even if it's just like a little tent on the side of the road, where people could just go get some supplies, especially with the hot weather coming. The hot weather is very rough on wounds, because you sweat and then you have it wrapped up, and that infection spreads with it, and so they get so much worse in the summer. And if you don't stay on top of it with clean bandages, you're just going to make it. It's gonna be a lot worse than it ever has to.
Yeah, I think that was really great, Sean and Brooke. And I also just wanted to add, I saw a few things in the Q&A about kind of when the use of Narcan should be used. And I think Sean mentioned this as well, but obviously if you're seeing someone down that's unresponsive, Narcan should be kind of the first step. And then obviously if the person does not respond to the Narcan, then you probably are realizing that the person is experiencing a Xylazine withdrawal. I think for most of the folks, like for instance, when I have Narcan people, they'll start to breathe because they're having a combination of a fentanyl and Xylazine overdose at the same time. So I'll administer the Narcan, they'll start to have some respirations, but won't be responsive. And that's where we kind of are able to really, as Sean mentioned, the sternal rubs, calling and yelling their name. And then at some points, we actually even use some water bottles that we have and just kind of spray that on the people, usually, obviously not near their face, but to kind of arouse them a little bit more. And that's something that we're kind of equipped with. And I feel like a lot of our teams also probably, across the country have water bottles, that we usually are giving out to people. So that's another resource just to make sure that, first and foremost, like as Xylazine gets introduced into the supply, it's usually introduced into fentanyl. So it's really important to really make sure that we're using Narcan first, just to make sure that we're preventing this, respiratory depression, and then acknowledging if the Narcan's not working appropriately or not working what it was previously when it was strictly a fentanyl overdose, then there's obviously a Xylazine component, and that's where you would use some other type of stimulation for the person. Brian, did you want to talk any bit further about any resources or support that you think would have been better to know about before Xylazine kind of hit Philly?
Just touching on something previously, with the overdoses too, I've seen ice on the back of the neck work really well when it's just Xylazine after the Narcan. For some reason, that just seems to wake people right up. But yeah, as far as Xylazine coming to your community, and if you're in the Northeast, it's probably already there. You just don't know it yet. It's just in small amounts, and as people get more and more addicted, it's going to become more of a problem. I think, like was said, the biggest thing is wound care supplies, and especially education and information for everyone down the line, from the addict to the EMT to the hospital workers, and letting them know, especially the addicts, that they can't ignore these wounds. As soon as they start, they need to get it treated, and it needs to be treated. It may cost $3 or $4 to treat that wound initially, or it can be ignored by everyone down the line and cost the community thousands and thousands of dollars, as well as a person losing their limb. And a lot of these people don't need to lose their limbs. They've lost them because of ignorance, and that's it, just people not knowing. And it's a shame. It's a shame. So many people I know just have lost so many limbs. It's almost ridiculous. It's just crazy. And these wounds are very treatable. I haven't seen one yet that was untreatable unless it was ignored. And people, when it gets to that point, people have ignored these wounds for 6 months to a year before it even becomes that bad. And it's just a shame because it doesn't have to happen.
Yeah, and just to add on to the wounds, I think a few people had messaged regarding the pictures and how long it took for those specific wound pictures to be clicked on that link to get to that extent. So usually we're seeing people kind of start out with wounds, maybe the size of kind of like almost, they look like cigarette burns on people's limbs, and then they kind of get quite extensive, I would say. And like probably those wounds were on the around 2 to 3 month period. And I think that's important to know, right? Because usually people are trying to kind of manage those wounds on their own for a long time, and there's a lot of a stigma attached to that. So that by the time our team is seeing them, usually they're quite progressed. And so it's just really important to make sure that you're really providing this harm reduction, as Brian said, wound care supplies and I know that wound care supplies are not cheap. And so if you're able to partner with any type of federally qualified health center, any type of provider organization that's actually able to bill your patients' insurances to get those supplies, that's a great option. I know in Philly we have Sean, works at Prevention Point. They have a nurse run wound care program that is able to provide low barrier wound care access that's based on people's like nursing license prescription. So they're able to kind of do a really needed service by providing drop-in wound care. And so if there's any resources like that, but I know it's difficult. And I know that's where sometimes people get these donations of the specialty dressings and they're like, we'll just use these, but just be really mindful of using those unless you actually have an order, because they can actually do more harm than good. And that's what's just really important to use, like, you know, the basic, you know, non-adherent conform and some tape and, you know, normal saline, kind of a water bottle to like pop to, you know, bare minimum. You don't need to do anything fancy. They just need to be covered and changed regularly.
I also wanted to highlight something about naloxone use. You know, yes, well, if we suspect an opioid overdose, the person is unresponsive, you go ahead and use naloxone. You know, given that xylazine is in the drug supply and it's heavily sedating people, it may not be our goal to completely wake them up quickly. It might, what we might want to do instead is gradual dosing. So maybe 0.4 milligrams intramuscularly, or maybe even lower. So we're kind of gradually waking them up, getting the respiratory rate back to normal. So it's not a shock when they wake up, because oftentimes what we see is, you know, somebody give initial 4 milligram, or God forbid, an 8 milligram initial dose, wait 2-3 minutes, give another one, wait 2-3 minutes, give another one, wait 2-3 minutes, and, you know, 4, 5, 6 doses. So we're talking about 24 milligrams of naloxone. And what's keeping the person unresponsive is this xylazine. So when the person does wake up, they were going to be in severe precipitated withdrawal. And that might be what wakes them up.
Right, exactly. Because if you administer enough Narcan, which is basically an amphetamine of sorts, eventually somebody's going to get up. But this is after several doses, which is unnecessary when you could just wait that time frame out, because they might have just sat right up like that at just over that time frame of 15-20 minutes doing a sternum rub. Or I've had success with using alcohol pads and I believe certain smelling salts might be of great assistance for people to actually attempt to use.
Thank you. Yes, I think the point you're making about, you know, the use of Narcan, I do think, especially for folks who aren't used to responding to overdose, there is a perception that you give Narcan and the person like jumps up right away, you know, and that has never really been the case, even for just opioids. And so when someone, you know, gives Narcan and sees that the person doesn't jump up right away, there is that impulse to like keep giving Narcan, and that can really cause unnecessary harm to somebody. It's very painful to have that precipitated withdrawal. And the thing we want to look for, as Sean said, is respirations. You know, you want to see if you give that Narcan and the person starts breathing again, then you know that Narcan worked, and now, you know, you're going to get that person into a recovery position and make sure that they're safe, and you're supporting them as they're kind of recovering from xylazine. So that's the big difference. And I think, you know, Sean, I think you could speak to this best, but in Philly, when we first had xylazine on the scene and we didn't know what was happening, people were giving a ton of Narcan because they didn't realize what was going on. And they thought it was just that there was so much fentanyl in the supply that we needed to give people like 4 doses of Narcan, but that wasn't actually the case.
Yeah, that's right. Even today, you know, again, when somebody's heavily sedated on xylazine or trank dope, which is fentanyl and xylazine, it looks like an opioid overdose. But again, you know, looking at some certain things just from our experience being out the street, talking with our participants who have that lived experience, gives us, you know, some more tools for our toolbox, some of those do no harm tools, such as water and things like that. We still see that a lot, people getting multiple doses of naloxone when it's really not needed. You know, if the breathing's not changing, you know, I don't want people to second guess, you know, is it an overdose? Are they just sedated on train? You know, we're looking at threats of life and how we're managing those threats of life, right? So whether we have Narcan or not, we're doing the basic life support measures, supporting airway, breathing, circulation above all. Narcan is great. It's a miracle drug. But I really want people to think about the ABCs, airway, breathing, circulation.
Thanks, all of you. So I think some of our questions we have touched on. One of the things that I think might be helpful for folks to hear, you know, I think Brooke and Brian, you have both had experiences in the healthcare system that have been really challenging. And so I'm wondering, kind of thinking about communities preparing, what would you specifically want service providers and medical providers to know about supporting people who are using xylazine if they are coming into healthcare settings for help? You know, like what are the things that you would want those people to be taught and to know about xylazine and supporting people who are using?
Yeah. Number one would be that to put it all out on the table. Don't just offer an amputation. Explain, ask questions. You know, if the doctor says an amputation, then, you know, and that's what he seems like, so, you know, hell-bent on doing, then, you know, you might want to get a second opinion. Go to another hospital, have them do a different kind of test. Don't give in so easily. They're worried we're not going to stay for 6 weeks of IV antibiotics. Try. I mean, like I said, with my arm, they sent me home in a week with oral antibiotics, and we were able to knock out a bone infection that way. I mean, after my surgery and whatnot, but still in all, like before that, that wasn't a thing that they even thought about doing. I mean, I just remember how quick they were to amputate my leg, and then this time they just wanted to save my arm so bad. And so, like, you will find the right place with the right doctors, because they are out there. They want to help us. They want to understand this more, just like, you know, we all do. We want to learn so we can help and overcome and possibly one day prevent this stuff from happening. And unfortunately, a lot of good people had to lose a lot of valuable limbs in order for us to get where we are. But progression is the number one goal. And the takeaway from all that is in the time lapse, like I said, in the last 2 years, I could tell you from firsthand, the same doctors at the same hospital came a very, very long way.
Yeah, we're all learning a lot as we go. I also believe there's no experts on xylazine. We're all learning,
Right.
and it's something that we're continuing to learn about.
Mm-hmm.
And that, I think that's just a fact.
Yeah, I think you both bring up a good point, which is really just about having communication and true dialogue with people in healthcare settings. You know, so often a medical person, you know, doesn't really hear what the person is experiencing or ask them what their goal is, or, you know, listen to what's happening for them and ask questions. And that makes such a big difference, to have a true dialogue, to really be able to ask someone, you know, do they think that they're at risk of having withdrawal from any substance, including xylazine? You know, talk about what their options are, talk about the concerns, you know, what are the different things they could do. And so many times that doesn't happen. And it's encouraging, Brooke, to hear that it has, you know, you had a better experience, you know, years later. But I'm also so sorry that you had the experience that you did with your leg. You know, it's so valuable now to be able to share this information to hopefully prevent these things in the future. So thank you for sharing that.
Not a problem. And if I can share that and maybe it helps somebody go get that other opinion that I didn't get, or, you know, just dig a little deeper to find that doctor out there that has genuine concern. Because like I said, they are out there, and you know, small sacrifices for the greater good. They kept my arm this time. So, like that's, one small step for normalcy, but a huge leap for addicts all over.
Yeah, I just want to add.
Go ahead.
Sorry, I just wanted to add a point, Brooke, that was just such an important point that you were making, and Sean as well. I think what our team has actually started to do, and we're, for team, medical team, but we actually work with homeless outreach workers that work, to get people connected to further case management services and housing resources as well. I know there were some questions about that, but we actually have tried to actually reach out to local healthcare organizations and see if they're interested in having their staff come out and shadow our team for the day. And although it's definitely a significant amount of work depending on the day to have another person shadow, but it definitely is something that I think carries a lot of good for our future healthcare professionals or future people working in the field to actually know where our folks are living. And I feel like I've brought out probably close to 50 people in the past year from different healthcare institutions in the Philly area. And each one on their first day is like, this is nothing that I would have ever expected. And I know that even when I had been seeing Brian, I had a medical student come out with me that day, and she was just blown away by our abilities to work with individuals on the street, but also all of the things that our folks have to deal with, whether it's police yelling at us for providing wound care, or just the unnecessary things that go into just the care that we're providing just to allow our patients to feel safe and supported. So if your organization is able to do that, and maybe you're not even providing medical care, maybe you're just doing outreach, and that's amazing. Maybe see if someone from your healthcare institutions can actually come out and see what you're doing, because I think finding these helpers in the healthcare institutions is so important for people to actually kind of have, we can talk the talk, and until these people actually see what we're doing, sometimes they don't actually believe it, and they should, but they don't. And I think that if we can try to increase people's knowledge about what our patients are experiencing from our wonderful content experts themselves, I think that and where they actually are living, it's so important to increasing healthcare awareness, and just, hopefully it will lead to better healthcare outcomes from our folks. And, thankfully, as Brooke mentioned, her arm was able to be saved, but there are so many people that weren't able to have their limbs be saved, and there's still a great deal of work that needs to be done.
It goes back to something I touched on too. A lot of these people are able to be saved, but they don't know any better. And my personal experience with my leg, I went to Jefferson Hospital 7 times. And each time they gave me an x-ray and oral antibiotics to go home with. And this is over about a year's time that this all takes. I go to Penn once and they do an MRI, and they ask me why I waited so long, because the infection got to the bone. And I said, waited so long? I've been going to Jefferson over this last year. Now, Jefferson has no records of me ever going there, but 7 different doctors from their hospital wrote me prescriptions I had filled at my pharmacy. Like, it's like almost like they denied the fact that they just didn't do that one extra test. Like, that's why I just said the second opinion is so important. And it's just because it could just be that one little thing, like the difference between an x-ray and an MRI, that could save so much.
Thank you. And I think we're coming close to the end of our time. So I just want to say thank you so much. And there are so many folks on here, and I think what Brooke and Brian and Sean and Hillary have highlighted is, for all of us who are working with people who may be experiencing these things, we actually have a lot of power to make a difference, and we can help people, learn how to and know that they can stand up for themselves and advocate, and we can be there to support people as well, and we can really make a lot of difference. So I just want to say thanks to everybody for being here and for wanting to learn more about this and to take it into your own communities. It has the potential to make a huge difference. So I'm going to share the code for the evaluation. And I think it was put in the chat too. If folks can do the evaluation to get the certificate, that would be great. And I just want to say thanks again to our panelists. This was so valuable. Everything you shared was really, really helpful. And I'm just so thankful that you were able to be here and share your knowledge and expertise with us. So thank you, everybody.
Thank you.
Thanks so much. And from HHRC, just a huge thanks to our panel and to our audience. We got so many great comments about how you were responding to the stories. Somebody said it best of Brooke and Brian, you are saving lives with your knowledge. So thank you so much. We'll make sure you get copies of all of the wonderful things that people said. We really just can't express enough how impactful and powerful the information shared today was. And so huge gratitude. If there's other questions, reach out to us at HHRC, and yeah, we'll keep putting out information to support this. So thanks, everybody. Have a great day.